causing end organ damage. That's great. Anything else? Thank you for bringing up oxygen, because I think that's the most important part. So what shock is, you broke it again, Magda. All right, so what shock is essentially inadequate oxygen delivery, inadequate to supply the oxygen that the tissue is demanding. It's typically a circulatory problem causing this inadequate oxygen delivery. There's a bunch of different causes, 5 pathophysiological variants: distributive, cardiogenic, hypovolemic, obstructive, and neurogenic. We're actually going to go through all of them over the course of this lecture, okay? But regardless of what causes it, the end result is the same. It's eventually irreversible multi-organ system failure and eventually death, unless you do something to stop it. And that's why it's so important. So what governs oxygen delivery? It's typically governed by these 3 things: cardiac output, oxygen carrying capacity, and tissue perfusion. So when I say inadequate oxygen delivery, that can mean reduced delivery of the oxygen, increased oxygen consumption, or inadequate oxygen extraction or utilization by those tissues. So again, all these different pathophysiological variants can contribute to shock in all those different ways, okay? And in fact, it often means all 3. So this is just kind of a schematic breakdown of that oxygen delivery. It's governed by cardiac output and oxygen carrying capacity, okay? So obviously cardiac output is heart rate times stroke volume, and oxygen carrying capacity is governed by the PaO2 and the concentration of hemoglobin, okay? So tissue perfusion is governed by, again, cardiac output and the systemic vascular resistance, the kind of tension on the vessels. If you have an inadequate systemic vascular resistance, that blood isn't going to make it to the tissues, okay? So even if you can have a really high cardiac output, you can have inadequate oxygen delivery. So again, stroke volume is primarily governed by preload, myocardial contractility, and afterload, whereas your SVR is governed by the vessel diameter or tone. And then 2 things that aren't really mutable, the vessel length and blood viscosity. Those don't really change too much in a normal stroke or in a normal shock setting, but vessel diameter can change quite a bit. So any process that affects any one of those parameters can lead to shock. So why do we care? And the reason is because tissue hypoxia affects every organ system. So you can see a variety of different symptoms when someone's in shock. With the brain, you eventually get encephalopathy, loss of consciousness. With the heart, you get myocardial ischemia. That's your typical type 2 STEMI or trope leak when you have a patient in shock. That's what that is. It's inadequate tissue perfusion of the heart leading to myocardial ischemia. With the kidneys, it's actually affected in 2 ways. Renal ischemia leads to ATN, and then decreased blood flow in general to the kidneys is going to decrease your GFR. In combination, those 2 lead to oliguria and eventually anuria. With your gut, you're going to have delayed gut motility or an ileus. You're going to have gut edema leading to poor absorption. So if you're giving a medication orally, or if you're giving tube feeds, they might not get absorbed as well in a shock state. And then finally, every tissue, your muscles, all the tissues I mentioned earlier, will kind of transition into this anaerobic metabolism. And that leads to lactic acid production and acidemia. All right, so like I said, there's 5 pathophysiological variants of shock. They can overlap, so it's important to keep that in mind. But basically, we're going to go through each of those 5 variants and kind of show how they affect the different parameters that we've discussed, okay? So first off is distributive shock. This is the most common form of shock, certainly worldwide and in this country. In the medical ICU, it's definitely the most common one you'll see. Essentially what this is systemic inflammation leading to vasodilation. So whatever the cause may be, it leads to this kind of catecholaminergic surge. And some of those catecholamines actually vasodilate and cause increased vascular permeability. And this leads to a decreased SVR. It can also lead to decreased intravascular volume too, which is also important. There's a number of different etiologies for distributive shock. Can we go through some of them? Sepsis, for sure the most common, for sure the most important. But what else? Can anything else do it? Anaphylaxis, absolutely. Pancreatitis, yeah. Cirrhosis. So that one's actually really interesting. So the way cirrhosis leads to this is the liver is responsible for clearing some of those catecholamines that lead to vasodilation. And if it can't do that, then you're going to just vasodilate. You lead to the systemic vasodilatory state. So that's actually kind of interesting. But yeah, definitely cirrhosis. Yeah, great, for sure. So yeah, I think you guys named a whole bunch of them that are really important. Sepsis, pancreatitis, vasoplegia from liver failure. You can also see that after a cardiopulmonary bypass. There's the so-called post-cardiac arrest syndrome. This is pretty important too. After a cardiac arrest, obviously that's a very pro-inflammatory state. And regardless of the etiology of the cardiac arrest, it's going to lead to systemic vasodilation. Other things we often see are drugs or toxins, trauma in general, same mechanism, just leads to an inflammatory state, burns, hypoadrenalism, all important etiologies, okay? So how do these patients present? How do they look when they come into your ICU? They look sick. Yeah, that's really important. They look toxic. They have a toxic appearance, especially if it's because of sepsis. You'll know if they're in shock. What else? Good. Yeah, so they're going to have warm, typically well perfused. Because of that vasoplegia and that kind of vascular leak, they may have edema. What's their heart rate going to be? Slow or fast? Fast, right. What's their pulse going to feel like? It can be thready, but can also be bounding. It really just depends on the patient. Good. So you should have these bounding pulses, wide pulse pressure, warm, wet extremities, and most importantly, they just look sick. When especially if someone's in septic shock, they'll look sick. And then we have these kind of physiological markers. What's their preload going to be in this state? Yeah, typically decreased. It can be normal, but typically it is decreased. What about the cardiac output? Yeah, typically high. There is an exception to that, and it's something called septic cardiomyopathy. Those same catecholamines and inflammatory markers can kind of cause a cardiomyopathy. So you may see a depressed EF. Yeah, that's certainly possible. And then kind of most importantly, what's their SVR going to do? Their systemic vascular resistance. Yeah, it's going to be real low. That's the most important thing. And then tissue oxygen uptake, that's what we measure when we're getting someone's mixed venous O2. Is their mixed venous O2 going to be high or low? Great. So preload, it can be normal. It can be decreased depending on how much vascular leak there is, how much how much decreased SVR they have. Their cardiac output is usually high, but again, it can be decreased. And the SVR, most importantly, severely decreased. So I think a really important part of shock and how we diagnose it and then eventually how we treat it is by using ultrasound, critical care ultrasound. So I think this is really important. And we're going to kind of go over that for each shock state as well. But first of all, when you're doing a critical care ultrasound, you're probably going to look at their heart first. So again, their cardiac function, it's often normal, but it can be hyperdynamic, which you can see here on the left-hand side. You can see how the walls of the left ventricle kind of clap. They're hyperactive. Typically, when you see an EF of like 65, the walls aren't clapping. I'm not an echocardiographer, but you can see that these walls are touching. And then you can also have a depressed EF. This is a good example of stress cardiomyopathy. This is actually a subxiphoid view here, so one of the easiest views to obtain. But you can see how the left ventricle, it's barely moving at all. That's a good example of stress cardiomyopathy. The next thing you'll probably look at is their IVC. And I don't think the IVC is a super reliable marker for someone's volume status, but it's certainly something you always look at. So it can be normal in sepsis too. But if they are hypovolemic because they've vasodilated and had a bunch of vascular leak, so they're intravascularly depleted, you may see a collapsible IVC. And then the lung exam, again, just another part of your critical care ultrasound. The lungs may be dry or normal, and then you'll see A lines. These are these A lines here in the top ultrasound. That's actually just a reflection of the pleural surface. So it's not like something in the lungs. It's just kind of an artifact that we use to tell us that, hey, these lungs are normal. But the lungs may also be wet, depending on the degree of capillary leak. You may have just kind of diffuse pulmonary edema. And that's, in that case, you'd see these B lines here. You can see these kind of vertical lines going down through the lungs. Those are a reflection that the alveoli are filled, okay? So you can see the diffuse B lines throughout if there's that degree of vascular leak. And then finally, if they have a pulmonary reason for their sepsis, for example, like if they have a bad pneumonia, you may see focal B lines or what we call pulmonary hepatization. That's just like where the lung looks like the liver. That's a sign of a pneumonia, okay? You may see an effusion. It just depends on what the etiology is, okay? And then finally, the treatment of distributive shock. Obviously, this is kind of the most important part. So once you recognize that, hey, this patient's in distributive or, septic shock, whatever, the most important part of treatment is addressing that underlying cause. Again, our most common thing here is sepsis. So antibiotics, right? Early antibiotics, I think, are one of those things that's really stressed nowadays. There's some debate as to how important it really is to get them in within the first hour, but regardless, antibiotics are important and source control. But then the other part of this is supportive care, okay? So I think there's, especially when I was in med school, there was kind of this idea that was drilled into us that just, pump them with fluids, give them a lot of fluids before you get to pressors. And I think that there's some validity to giving fluid, but we need to be more judicious about our fluid administration. I think a lot of cases of like ARDS or respiratory failure in sepsis are kind of iatrogenic. We pump these people with like 4 liters of saline, and then they're like, oh, why are their lungs wet? It's because we gave them 4 liters of saline. So I think you have to actually assess their volume status, see if they do need fluids before you just plug them with fluids. And then finally, pressors are obviously a major part of this. This is like Chris said, they need pressors when they're in shock. Yeah, it's probably true. So we use norepinephrine most commonly. That's our first line agent. Then vasopressin and epinephrine or phenyl, depending on the patient, okay? So basically what you're doing here is supporting the patient, giving time for your antibiotics or whatever else to work, and hoping they do well enough that they survive it, okay? All right. So that's distributive shock. Do you guys have any questions so far? And there'll be time at the end, of course, okay? Let's move on to cardiogenic shock. So cardiogenic shock is due to left ventricular dysfunction, left-sided pump failure. The left side of your heart is inadequate at delivering the blood and therefore the oxygen to the tissues, okay? So decreased cardiac output leads to decreased oxygen delivery. There's a number of different etiologies for this. Why don't we go through a few of them? Sorry, go ahead. Sure. An MI, especially on the left side, what does that MI do? Yeah, so basically the MI kills cardiac muscles, like you said, and basically reduces your EF because that dead muscle can't pump. What else? Sorry, go ahead. Tamponade. That's actually a different kind of shock, and we'll talk about that a little bit later. Good. Aortic stenosis or valvulopathy in general on the left side. So aortic or mitral stenosis can do it. Good. Arrhythmia, absolutely. So especially a ventricular arrhythmia, something like VTAC. Essentially, when the heart's fibrillating or in ventricular tachycardia, it's not pumping, right? Because the muscle's just kind of shaking around. It's not doing a good job of pumping that blood to the rest of the body. So LV failure, first of all, like you said, an MI. There's also Takotsubo cardiomyopathy, stress cardiomyopathy, which I'm sure you've all heard of. Myocarditis, postpartum cardiomyopathy, acute exacerbations of heart failures. And then, like I said, ventricular arrhythmia or bradyarrhythmias. They can all basically decrease your cardiac output. Valve failure, like aortic stenosis or failure of a prosthetic valve. Endocarditis can do this as well. And then post-MI, another complication is papillary muscle rupture. That's, again, going to cause your valve to fail. And then finally, the other thing to consider is obstruction of your left ventricular outflow tract. We don't see a whole lot of this in the medical ICU, obviously, but you can see it in the cardiac ICU, basically the left ventricle muscle gets so hypertrophied that it blocks your LV outflow tract, and that prevents blood from getting out of the heart, right? So that is another way you can cause heart failure. Okay, good. How do these patients present? Sorry, say that again. Go ahead. Cold extremities, good. Pulmonary edema is very common. Edema everywhere, right? What else? What's their pulse going to feel like? Weak and thready for sure, yeah. Yeah, I mean, shock in general can cause altered mental status, right? Good. So like you said, cold, clammy extremities, they often have peripheral edema, pulmonary edema, thready pulses, a narrow pulse pressure. But what's actually interesting is oftentimes these patients in cardiogenic shocks look deceivingly good, especially if you compare them to your patients in septic shock or distributive shock. They look okay, but they're in shock. And that's, you know, I don't necessarily have a great explanation for that. I think it's oftentimes you see these patients in the setting of decompensated heart failure. So it's something that kind of happens slowly. Their body's kind of adjusted to it. And then you're treating them acutely. So you'll see that a lot more in the cardiac ICU, obviously, than ours. Good. So what's going to happen to your preload in cardiogenic shock? It increases. What about your cardiac output? Yeah, that's the big problem, right? Is your cardiac output's trash. And then good, your SVR. Good. Your SVR will be increased. And then finally, your SVO2. Is this going to be up or down? Down. So basically, the way that you can kind of conceptualize this is the heart is really bad at pumping. So blood is taking its time going through all the tissues and coming back to the heart. And when you're measuring an SVO2, typically you're measuring it ideally in the pulmonary artery, more often maybe in like the IVC or SVC. By the time it gets back to that point, all the oxygen's been extracted from it because it took its time going through all the different tissues, okay? Good. So preloads usually increase. It can be normal, of course. Your cardiac output is severely decreased. It's important to note that you may not have a depressed EF, right? Like if you have a valvular abnormality, your EF might be fine, but the aortic valve is completely stenosed. Your SVR is usually increased. And then finally, your mixed venous oxygen is going to be low. Obviously, echocardiogram is important for cardiogenic shock. So there's multiple different ways that the heart can look in cardiogenic shock. And that kind of just relates to different etiologies. So here, LV systolic failure, you have an apical four-chamber view. You can see the left ventricle is barely pumping at all. Severe aortic stenosis, this is a parasternal long axis view. You can see the aortic valve here barely moving. It's severely stenosed. And obviously you can kind of figure that, the aortic valve's here. You can kind of figure that not a lot of blood's going to be going through that bad boy. And then finally, LVOT obstruction. This is an example of HOCM. You can see the left ventricular, interventricular septum wall here is huge, and it's obstructing the LV outflow tract. Your IVC, typically it's going to be dilated and non-compressible. You can see an example of that here. Again, the IVC measurement is super unreliable unless your patient is intubated and paralyzed and on a high enough tidal volume setting that we don't really use. So I urge you not to rely on that as your end all be all, but it's again, another bit of evidence you can use. And then your pulmonary exam, you should see diffused B lines, again, indicating diffuse pulmonary edema. So how do we treat cardiogenic shock? And again, it kind of depends on the etiology. You want to address the underlying cause, which is true for any kind of shock. If you have decompensated heart failure, you may need inotropic agents, or if they're severely hypotensive, maybe inopressor agents like norepinephrine or epinephrine. You may need to diurese them to kind of remove some of that preload or an and afterload, give the heart less to pump against. If it's because of myocardial ischemia, they obviously need to be revascularized. Otherwise, the problem is kind of just going to get worse. Ventricular arrhythmia and hypotension. You guys took ACLS, you kind of know you gotta shock them, right? If it's due to a valvulopathy, the valve probably needs to be fixed. And then LVOT obstruction. Again, this is not something you see a ton in our ICU, but it's actually kind of counterintuitive. In this situation, inotropic agents aren't going to help you, okay? You actually need to stop the inotropic agents because that's just going to make the LV contract harder and actually worsen the degree of obstruction. You often have to give additional volume in order to make the LV size a little bigger and kind of relieve that obstruction. So that's kind of the summary of cardiogenic shock. We'll next move on to hypovolemic shock. This is another pretty common one in the medical ICU. And this one makes sense, right? It's due to intravascular volume depletion. That causes reduced preload, which causes reduced stroke volume, which causes reduced cardiac output, okay? And therefore inadequate oxygen delivery. What are some etiologies for this one? Gunshot wound. Getting right after it. Yeah. So what does a gunshot wound do? You bleed, right? So there's kind of two ways to look at hypovolemic, or two kind of variants. There's hemorrhagic and there's non-hemorrhagic. Okay. So gunshot wound would be an example of hemorrhagic hypovolemic shock. What are the some other hemorrhagic ones? Probably more common in the medical ICU. GI bleed for sure, right? I mean, that's probably the most common hypovolemic shock that we'll see. What else? CHF exacerbation would be more under the cardiogenic. It doesn't typically cause hypovolemic shock. Sure. So that one's actually interesting because what that'll do is actually decrease your oxygen carrying capacity. So in a sense, some of the pathophysiology is shared with hypovolemic shock. Yeah. Good. Overdiuresing. So that's a great example of iatrogenic, non-hemorrhagic cardiogenic shock. Intractable vomiting for sure. Diarrhea too, right? GI losses. Burns can do it too. If you have someone with SJS or 10, they're losing a ton of volume just from their skin, okay? So yeah, trauma is the most common overall cause of hemorrhagic shock. Not in our ICU because we don't really take care of trauma, but certainly can happen. GI hemorrhage or other hemorrhage, whether that be operative, retroperitoneal bleeds, we see kind of, I would say infrequently, but we see them. Hematomas, you always got to check their thighs because you just have to think about the compartments that can hold a lot of blood. Your thorax, your abdomen, your thighs are pretty much the ones that can do it. Non-hemorrhagic is also really important. So like I said, GI losses, diarrhea, vomiting, dumping syndrome in our post-bypass patients, burns, renal, you can see people just really peeing out a lot of fluid, and then severe third spacing. So there can be a component of this when you have distributive shock as well, or really bad cirrhosis or nephrotic syndrome, whatever. So how did these patients present? Yeah, so if they're hemorrhaging, there's, oh, I came in, I just got shot. Yeah, you'll probably suspect it then, or hey, I've been having a lot of blood from below. So yeah, if they're showing signs of bleeding, they'll present like that. Yeah, they should be tachycardic, definitely. Sorry, say that again. Yeah, for sure. What's their pulse going to feel like? Yeah, weak and thready. And what about their pulse pressure? Do you guys know what I mean by pulse pressure, by the way? Okay, good. Yeah, narrow, good. Yeah, so hemorrhage, if they're showing signs of hemorrhage like melena, hematochezia, a tense abdomen after a surgery, for example, big hematoma on their thigh, yeah, you might be able to see that. You might not be able to if it's like a retroperitoneal bleed. Those are often kind of occult, but oftentimes you'll know. They'll be tachycardic, narrow pulse pressure. So nice I had to say it twice apparently. Pale skin and a slow cap refill, okay? So here, what's their preload going to be? Low, for sure. That's the problem, right? Low preload. What about their cardiac output? Low, exactly. Low preload, low stroke volume, low cardiac output. What about their systemic vascular resistance? Yep, good. And then tissue oxygen uptake. What's their SpO2 going to be? It kind of depends. It may be normal, maybe to reduce. It just depends on the severity of the hemorrhage. But good. So their preloads severely decrease. Their cardiac outputs usually decrease. I say usually because sometimes if you've got a very healthy heart, you can compensate for that with just really a lot of tachycardia, and your SVR is going to be increased. All right, so what's your ultrasound going to look like? Your left ventricle may be hyperdynamic. Again, the decreased preload, the heart's going to try to compensate, so it'll increase its contractility, increase your heart rate, and squeeze a little bit harder. Your IVC, typically in this case, it should be collapsible, it should be narrow, again, because you're hypovolemic. And your treatment here is volume resuscitation, okay? And it really depends on what your etiology here is. So for hemorrhagic shock, it's important to give blood product. You can't just give these patients saline or LR and expect them to do okay. And that's, again, kind of like we discussed, they're going to have a low oxygen carrying capacity. And if you just plug them with saline, that's going to dilute their blood further and further reduce their oxygen carrying capacity, okay? So it's important to resuscitate with blood products and not just crystalloid. For non-hemorrhagic shock, depending on the etiology, they're probably losing electrolytes too. So you have to keep a close eye on their lights and replete them as needed along with giving them volume, okay? All right, moving on to obstructive shock. So when we talked about cardiogenic shock, we were talking about an LV obstruction and typically due to something intracardiac. When it comes to obstructive shock, we're talking about something extracardiac. It can be just outside the heart, like in the situation of tamponade, or it could be in the lungs. It really depends, okay? But the point is, it's caused to some obstruction, which results in usually reduced RV function rather than LV function. So a lot of different etiologies here, and they're all kind of fun. This is a rare one we don't see too often, but when we find it, it's kind of fun. So what are some etiologies here? Massive PE, great. What does that do? Yeah, how? Great. So it basically increases your pulmonary vascular resistance because some of it gets blocked up. The RV has to work harder to overcome that, or sometimes it can't overcome that and fails. And that's when you get obstructive shock. Tension pneumo, great. Same deal here. Basically, it severely increases the intrathoracic pressure and the RV can't pump against it. Tamponade, we talked about it, right? So this actually causes reduced RV function. Basically, the fluid in the pericardium or inside the pericardium around the heart causes compression of the RV can't take it, reduce RV function. Anything else? So ones we don't see too often, or I should say we see pretty often, is severe pulmonary hypertension. This is the same thing. It's analogous to heart failure. Basically, if you have severe pulmonary hypertension, something exacerbates it. Maybe you get volume overloaded. The RV can't function anymore, and you go into what is really obstructive shock. You can see it in acute pulmonic valve or tricuspid valve stenosis, and then fat embolism. This is a rare etiology, especially in an RICU. You know, you typically see this after a broken femur, so maybe a trauma, for example. But again, it can happen. You can also see it by these mechanical causes causing decreased preload, reduced venous return to the right atrium, or impaired RV filling, like we talked about. So tension pneumo, tamponade, less common things like an abdominal compartment syndrome. You can see that with, for example, pancreatitis. Basically, it impairs your RV filling. Constrictive pericarditis, again, not a super common etiology, but something you can't see. So how do these patients present? Edema, typically, yeah, because the RV fails. So it's going to fail backwards. It's like a pump, right? So you're going to have filling or failure with edema. You might not necessarily have pulmonary edema, right? Because it's the RV that's failed, but lower extremity edema, presacral edema. JVD, great. This one's a little tricky. And the answer is it kind of depends on the etiology. So for example, what's their heart going to sound like if they have tamponade? Muffled, right? If they have a PE, there might not be super obvious signs, but maybe they present with like pleuritic chest pain, or, you know, I recently had surgery 3 days ago and now I have, you know what I mean? Things like that. So you may see signs of RV failure, but they may not be present depending on the acuity. You should have a narrow pulse pressure again, because it kind of shares some pathophysiological similarities with cardiogenic shock, and a weak thready pulse. And then the other signs are going to kind of depend on the etiology. So what happens to your preload here? Your preload is down. Good. What about your cardiac output? down, right? Because, the LV can't fill if the RV has failed, right? What about your SVR? Good, increase. And then your SVO2, up or down? What do you think? Anyone? Your SVO2 should be down, right? Because again, this is another similarity to cardiogenic shock. The blood's gonna take its time going around to all the tissues, extracting all the oxygen out. So preload is normal or decreased. Again, it depends on the etiology. Cardiac output is going to be decreased, and your SVR is going to be increased. All right, so this is probably the etiology of shock where your POCUS exam is most important, okay? Because this is where you can actually be a doctor and figure out what's wrong with them at the bedside. It can be pretty fun. So a massive PE, sometimes you see a thin dilated RV with what we call McConnell signs. That's where you look at the RV apex right there. You can see that it's kind of hypercontractible. It's kind of pulling in, right? Do you guys kind of see that? Whereas the mid wall, it's not really moving as much. That's McConnell sign. I personally have never seen that guy, but I've seen a blown RV. That's something I think we've all seen. Severe pulmonary hypertension, if this is like a pulmonary hypertension exacerbation, you should have a thicker RV because pulmonary hypertension is probably something that this person's dealt with for a while. So their RV kind of hypertrophies. And then you'll see evidence of cor pulmonale, where the RV is kind of impinging on the LV. Pneumothorax. This is something that's super diagnosable with an ultrasound. And we look for something called lung sliding. So what lung sliding is, and you can kind of see it on the left-hand side of this first ultrasound, you can see the pleura, the pleural surfaces sliding against each other with each inspiration, okay? But in this particular ultrasound, you see what we call a lung point. So an area where you go from lung sliding to no lung sliding. This is super specific and sensitive for pneumothorax. I've only seen this a couple of times, even with obvious pneumothorax cases. But if you do see it, that's a slam dunk pneumothorax. So pneumothorax is something that's really identifiable with your ultrasound exam. And again, if someone's crashing, you identify a pneumothorax, you obviously know you need to decompress that. And then tamponade, you can see that on the right-hand side here. You see this large pericardial effusion, all this fluid around the heart. You see that the RV, which you can see here, it's kind of bulging into the LV. You see a diminished RV volume because it can't fill as well. Those are all evidence of tamponade physiology. And again, these are all things that you as a resident you can wheel the ultrasound into the patient's room and look for these things. And if you find it, tell your fellow. But these are all things you can find. It's pretty cool. I would prefer you don't decompress that tamponade by yourself, Chris. I did let Chris do a chest tube once, so I mean, play your cards right. But you're welcome. All right, so the treatment depends on the etiology, right? Because at the end of the day, all we do with pressors is support people, keep them alive long enough that you can fix the underlying problem. And what the underlying problem is, it depends on the etiology. So with a PE, this is your situation where you start thinking about things like TPA. You activate the PE response team, PERT team, to consider mechanical thrombectomy. It kind of depends on how stable they are. If they're mid cardiac arrest, you don't have time to wheel them down to the cath lab for a mechanical thrombectomy. You're just pushing TPA. But if you have some time, they're like in shock but not dying right in front of you, you might have time to do a PERT. If it's pulmonary hypertension, typically we use inotropes like dobutamine, milrinone, depending on which one they're responding to better. We use pulmonary vasodilators. You'll see these patients in our MICU. And Dr. Gagermeyer, who I'm sure you all meet, will call you about them at 2 a.m. Tamponade, you can do a pericardiocentesis or a pericardial window, not you specifically, but the cardiologist that you call can do that. And then same thing for constrictive pericarditis, pericardiectomy. Good. So that is obstructive shock. And then our last, but probably least actually, is neurogenic shock. This one, frankly, we don't see in our ICU. You'll see it in the neuro ICU, and you might see it in the trauma ICU, but you won't see it so much in our ICU. So similar to distributive shock, this is basically a state of systemic vasodilation. And it can be really severe. Their SVR decreases dramatically. But not similarly to distributive shock, you don't see any compensatory response from the heart. So your stroke volume doesn't increase, your heart rate doesn't increase. Oftentimes they even get bradycardic. So you're kind of fighting two battles at once. What are some etiologies for neurogenic shock? And I kind of give you a clue here. Interruption of their autonomic nervous system. Spinal shock. So what causes spinal shock? Good. Spinal artery occlusion. That's again pretty rare, but it happens for sure. Trauma. That's the most common and most important thing. So let's say you have a trauma and it results in like a C2 fracture and damage to the spinal cord at that point. That can cause this kind of autonomic nervous system interruption. You can see it with TBI too. So I mean, not that this is something you'll see so much here in Maywood, but like it was often seen with like war veterans. They had a bad TBI and they go into shock. What caused it? It's because of interruption to their autonomic nervous system. So again, those are the most common etiologies. You can see this with spinal anesthesia, super, super rare. So how do these patients present? So kind of think back to your distributive shock and then also the stuff about the heart. They'll be warm. Maybe not though, right? Because their heart isn't doing the job. So maybe maybe their pulse is bounding, maybe it's not. Maybe it's super bradycardic, you know, it's pretty common. Most importantly is the history. If they had some sort of spinal trauma or whatever, your history should provide some clue. You should have hypotension. You should still have a wide pulse pressure. And then again, bradycardia. So here, what's going to happen to your preload? High or low? Can be. It depends. Cardiac output? Typically low, honestly, because they get bradycardic. And remember, stroke volume times heart rate. Your SVR? Low. And then your mixed venous, it can be up or down. So again, kind of everything decreases. There's no specific ultrasound science here. If you put an ultrasound on them, oh, they're bradycardic and they're in shock, maybe that gives you some clue. But again, there's nothing really specific here. And then treatment. Unfortunately, there's kind of no real good treatment for this. There's no magic bullet that'll fix them. They typically do recover with time. So basically the autonomic nervous system reinnervates itself. But all you can do is really support them. So you give them inopressor agents like norepinephrine, you give them fluids. Their heart rate might not respond to that. You know, you can give them epinephrine and they may still be bradycardic. All you can do is try and help their vasculature kind of tighten up, increase that vessel tone, and hope for the best. Sorry, what's that? You can pace them, yeah. Typically, though, the mainstay is to really just tighten up their vessels. Good. So I'm going to leave this slide up there for a while if you want to take a picture of it. It's kind of a handy reference. I don't know, Magda, do you send out slides at the end of these things or? Okay, so you can take a picture of it now or later. But this is just kind of a summary slide of everything we just talked about. So I'll leave it up for like a couple seconds. All right. Do you guys have any questions? It's kind of a lot. Shock's scary. Okie dokie. Well, thank you guys and good luck with this year. I just did such a good job.